Today, I'd like to introduce two speakers regarding the management of NAFLD and MAFLD and sarcopenia in NAFLD and MAFLD. So for the first speaker, I'd like to introduce Professor Wang Chen. Dr. Chen is Professor of Medicine at the University of Malaysia and the Senior Consultant, Gastroenterology and Hepatologist at the same University Medical Center and Special Center. He is a member of Academy of Medicine of Malaysia, and Malaysian Society Gastroenterology and Hepatology, and ASLD, the American Association for the Study of the Liver. He was scientific co-chair for the APDW, Asia Pacific Digestive Week this year, 2021. And he is a member of Asia Pacific Working Party on Non-Alcoholic Fatty Liver Disease and the Gut and Obesity in Asia Working Group and CAP Prognosis Study Group and the Global LASHI Council. For the editorial work, he is Associate Editor for the Journal of Gastroenterology and Hepatology and a member of editorial board for the Clinical and Molecular Hepatology and a reviewer for the many good peer-reviewed international journals. He has published numerous full papers in good journal and presented both local and international conferences. His main area of research interest is the metabolic dysfunction associated with fatty liver disease. This is a very hot topic these days, and he will give us talk today entitled Comprehensive Management of NAFLD and MAFLD. Please, Professor Chen.
Thank you, Professor An, for your kind introduction. A very good evening to you, as well as Professor Kim, friends and colleagues from China, Korea, Malaysia, as well as other parts of the world who have tuned in for today's webinar, which is brought to us by Hisky. I've been given the task to talk on comprehensive management of NAFLD or MAFLD. To set the stage, we will first look at the definition of NAFLD. NAFLD or non-alcoholic fatty liver disease encompasses a spectrum of liver conditions that are characterized by excess accumulation of fat in the liver. We know that the majority of cases are related to overnutrition, and for strict definition of NAFLD, significant or excessive alcohol intake and other causes of chronic liver disease must be excluded. This is the spectrum of NAFLD. At one end is simple steatosis, whereas NASH or non-alcoholic steatohepatitis is the more severe form of NAFLD that's defined histologically by the presence of hepatocyte ballooning and lobular inflammation. Patients with NASH are at increased risk of developing fibrosis and progressing to cirrhosis. Patients with NASH, especially in the presence of advanced fibrosis or cirrhosis, are at increased risk of developing liver cancer as well as decompensated liver disease. On the other hand, patients with NAFLD across the board are at increased risk of cardiovascular disease due to the close association of NAFLD with the metabolic syndrome. This is the natural history of NAFLD. The annual incidence is 3 to 4%, and among patients with simple steatosis, 25% progress to NASH and have fibrosis progression in an average of 3 years. Patients with NASH have fibrosis progression on an average of 1 stage in 7 years, while patients with simple steatosis has fibrosis progression on average of 1 stage in 14 years. Patients with cirrhosis develop liver cancer at a rate of 1 to 4% per year. This slide is very important. It shows us that the fibrosis stage is the single most important predictor of liver-related complication and mortality in patients with NAFLD. As you can see here, patients with stage 2 fibrosis are nearly 10 times more likely to die of liver-related complications during follow-up, and the risk of mortality increases exponentially, so much so that patients with cirrhosis are over 40 times more likely to die of liver-related complications than patients who have a lower stage of fibrosis. There are some fundamental issues with the term NAFLD. First of all, individual patient may have more than one cause of chronic liver disease. For example, we often see patient who has fatty liver and obesity who consume more than a modest amount of alcohol. We also often see patient with chronic hepatitis B who has fatty liver due to obesity. The term NAFLD requires exclusion of significant alcohol intake as well as other causes of chronic liver disease in its definition. On the other hand, the term NAFLD also does not attribute the condition to its underlying etiology. We know that the majority of cases of NAFLD are related to obesity and the metabolic syndrome. Because of these fundamental issues, Eslam and colleagues have come up with a new term, metabolic dysfunction associated fatty liver disease, or MAFLD. It is diagnosed in a person who has hepatic steatosis, who is overweight or obese, has type 2 diabetes mellitus, or has at least 2 metabolic risk abnormalities. The metabolic risk abnormalities include the criteria for metabolic syndrome, and in addition to that, elevated HOMA-IR or elevated hsCRP level. The term MAFLD has been endorsed by the Asian Pacific Association for the Study of Liver, as you can see in this clinical practice guideline that was released last year. The term MAFLD has also been endorsed by our Malaysian Society of Gastroenterology and Hepatology. This is a very nice paper comparing MAFLD and NAFLD. As you can see, the majority of patients who meet the criteria for one would meet the criteria for the other. And among those 5 to 8% of patients who meet the criteria for NAFLD but do not meet the criteria for MAFLD, they actually have fatty liver with no or only very mild metabolic dysfunction. It has been shown that these patients tend not to have significant liver disease, and it is still unknown whether the diagnosis in this patient would really make a difference in terms of their long-term outcome, instead of waiting for them to develop a metabolic dysfunction and to be diagnosed with MAFLD to undergo intervention. On the other hand, 5 to 8% of patients will fulfill the criteria for MAFLD but not NAFLD. These are actually patients who have fatty liver but at the same time consume a significant amount of alcohol or have other causes of chronic liver disease. And it has been shown that these patients tend to have more severe liver disease. All in all, these support the new term MAFLD as compared to the older term NAFLD. With that, we will move on to the focus of today's talk, which is on comprehensive management of NAFLD or MAFLD. These are the topics that I'll cover during today's talk. First, we'll look at lifestyle intervention. As we know, lifestyle intervention is the cornerstone in the management of NAFLD or MAFLD. In this study, Professor Villa-Gomez enrolled nearly 300 biopsy-proven NASH patients into a comprehensive lifestyle program for 52 weeks. The patients had repeat liver biopsy at the end of the study. As you can see here, as the total body weight loss increases, the proportion of patients who had NASH resolution increases, so much so that 90% of those patients who have lost more than 10% of their body weight had NASH resolution. And 45% of these patients even had fibrosis improvement. This is another study by Professor Vincent Wong's group. It's a randomized control trial of 154 adults with NAFLD diagnosed by MR spectroscopy. They were randomized to receive either a dietitian-led lifestyle modification program or usual care for 12 months, and the primary outcome was remission of NAFLD based on MR spectroscopy. And as you can see here, the proportion of patients who have remission of NAFLD increases as the amount of weight loss increases, so much so that that 97% of those patients who have lost at least 10% of their body weight had remission of NAFLD. This is a subsequent publication on the same cohort of patients where patients were stratified to obese and non-obese group. And as you can see here, regardless of their obesity status, patients who achieve increasing amount of weight loss, an increasing proportion of them had remission of NAFLD. This tells us that lifestyle intervention aiming to achieve weight loss can work for both obese as well as non-obese NAFLD patients. I usually advise patients with NAFLD or MAFLD to limit their alcohol intake. This is a nice study by Professor Ashmira's group. They included 285 participants in NASH CRN who had paired liver biopsy but who were not receiving a pharmacologic therapy in clinical trials. The mean follow-up between liver biopsy was 47 months, and in the study population, 59% were actually modest alcohol drinkers, while 41% were non-drinkers. As you can see here, the percentage of patients with NASH resolution was highest among those patients who were never drinker. This was followed by those patients who were modest drinker at the beginning of the study, but became a non-drinker at the end of the studies. And the percentage of patients with NASH resolution was lowest among those who continued to be modest drinker throughout the study period. Among patients with established cirrhosis, I would advise against alcohol use. This is because there have been studies showing that patients with cirrhosis who continue to use alcohol at increased risk of liver decompensation as well as liver cancer. This is one such study. As you can see here, the proportion of patients who develop liver cancer was significantly higher among those who consume alcohol compared to those who do not during follow-up. Instead, I advise patients to consider taking coffee. There have been multiple studies showing that coffee drinker versus non-drinker has lower risk of NAFLD. And among those patients with NAFLD, coffee drinker has a lower risk of liver fibrosis compared with non-drinker. As we have heard earlier, patients with NAFLD or MAFLD are at increased risk of cardiovascular disease. In fact, cardiovascular disease is the leading cause of mortality in our NAFLD or MAFLD patients. That is why we need to recognize and optimize control of metabolic risk factors in our patient with NAFLD or MAFLD. It is highly recommended that LDL cholesterol level be treated to target based on an individual's cardiovascular disease risk. This is to reduce the risk of cardiovascular event and mortality. Many guidelines recommend this, including the AACE guideline. The Framingham risk score estimates an individual's cardiovascular disease risk. It uses several parameters which include age, total cholesterol, HDL cholesterol, systolic blood pressure, as well as smoking and diabetes status. You can use an online calculator for the Framingham risk score. You can also look at the major independent risk factors individually, which include a high LDL cholesterol, polycystic ovarian syndrome, cigarette smoking, hypertension, low HDL cholesterol, family history of coronary artery disease, chronic kidney disease, evidence of coronary artery calcification, as well as age more than 45 in men and more than 55 in women. Based on the Framingham risk score as well as the presence of the major risk factors, patients can be categorized as extreme, very high, high, moderate, or low risk of cardiovascular disease. And their LDL cholesterol target would be less than 1.4, less than 1.8, less than 2.6, less than 2.6, and less than 3.4 millimole per liter respectively. One easy way to look at this table would be to look at the presence of diabetes. In a person with diabetes, even when there are no other risk factors, he or she will immediately be in the high risk category, and the LDL cholesterol target would be less than 2.6 millimole per liter. In a person with diabetes with at least one other risk factors, the person would be in the very high risk category, and the LDL cholesterol target would be less than 1.8 millimole per liter. There is a reason why I emphasize dyslipidemia and treating LDL cholesterol to target among NAFLD patients. In this multi-center study across Asia, we found a very high proportion of patients with dyslipidemia, but a disproportionately low use of statin among these patients. This was a retrospective study. In a subsequent prospective study, we again found that there's a disproportionately low statin use among NAFLD patients. Furthermore, we found that among those patients who were not on statin, 3/4 of them should have been on a statin, and among those patients who were on statin, nearly 60% of them were not treated to target. This highlights the suboptimal treatment of dyslipidemia among NAFLD patients. Besides dyslipidemia, we should also remember to diagnose other metabolic risk factors and manage them accordingly. A target blood pressure of less than 130 over 80 millimeter mercury is appropriate for most patients, while a HbA1c level of 6.5% and below is considered optimal if it can be achieved in a safe and affordable manner. Patients who smoke should be advised to stop smoking to reduce their metabolic risk. Next, we'll move on to assessment of severity of liver disease. As a background, I would like to refer to this paper by Professor Vincent Wong's group. It's a study using a magnetic resonance spectroscopy and transient elastography in the general population. And as you can see here, there's a high proportion of the general population who has got NAFLD, but only a small proportion have advanced liver disease. So how do we ensure that NAFLD or MAFLD patients with more severe liver disease are identified and are referred for appropriate care? At the same time, how do we reduce unnecessary referrals? To answer to that question, I would like to highlight that diabetes mellitus is a risk factor for more severe NAFLD. In this multi-center Asian study that included over 1,000 biopsy-proven NAFLD patients where the main indication for liver biopsy was persistently elevated liver enzymes, where 63% patients were found to have NASH and 17% were found to have advanced fibrosis, diabetes mellitus was recognized as a risk factor for NASH as well as a risk factor for advanced liver fibrosis. To add on further to this point, this is a study using transient elastography in the diabetes clinic of my hospital. We found that 72% of these patients have significant hepatic steatosis and 21% of them had advanced liver fibrosis. Furthermore, among those patients with liver stiffness measurement 8 kilopascal or greater who were referred for further assessment, and those patients who underwent liver biopsy, we found that the majority of them had NASH and some degree of liver fibrosis. And more than 1/3 of these patients have histologically confirmed advanced liver fibrosis. All this point to the fact that patients with type 2 diabetes mellitus represent an important target group to identify people with more severe MAFLD. Because of that, a section on NAFLD or MAFLD has been included for the very first time in the clinical practice guideline on management of type 2 diabetes mellitus in Malaysia. You can review the guideline using the QR code in this slide. The inclusion of a section on NAFLD or MAFLD in the clinical practice guideline for management of type 2 diabetes mellitus here in Malaysia has been cited as one of the potential strategy to tackle NAFLD or MAFLD by this paper, which was published by the Economic Intelligence Unit and the European Association for Study of Liver, International Liver Foundation. You can read more about other strategies by using the QR code shown in this slide. Next, I'd like to take you through the simple assessment and referral pathway that can be found in the clinical practice guideline for management of type 2 diabetes mellitus. Of course, the strategy may be different depending on your local setting. Here in Malaysia, we recommend simple blood tests like the full blood count and liver function test as part of assessment of patients with type 2 diabetes mellitus. For those patients who have normal ALT and AST, we can repeat the test annually. For those who have elevated ALT and AST, we should exclude other causes of liver disease, for example, alcohol, drug-induced liver injury, chronic hepatitis B and C infection. An ultrasound should be performed to diagnose fatty liver and to exclude focal liver lesion. Once it is established that the elevated ALT and AST is due to fatty liver, lifestyle advice should be given, and the patient can have a repeat ALT and AST after 3 to 6 months. However, if the cause of the elevated liver enzyme is uncertain, or if the patient has persistently elevated ALT, AST despite lifestyle modification, the patient should be considered for referral to a gastroenterologist or hepatologist. And besides ALT and AST level, it is recommended that the patient has assessment for liver fibrosis using fibrosis 4 score. Those patients with fibrosis 4 index less than 1.3 can have this repeated every 2 to 3 years, while those who have fibrosis 4 index 1.3 or greater should be referred for liver stiffness measurement and can be considered for referral to gastroenterologist or hepatologist. A guide has also been included for interpretation of liver stiffness measurement. Patients with liver stiffness measurement less than 10 kilopascal are considered unlikely to have advanced liver fibrosis. Based on previous study, the negative predictive value for advanced fibrosis is between 93 to 97%. Those patients with liver stiffness measurement 10 to 15 kilopascal may have advanced liver fibrosis. They require monitoring, for example, repeating liver stiffness measurement after 1 year, and can be considered for referral to gastroenterologists and hepatologists. Those who have got liver stiffness measurement more than 15 kilopascal are likely to have advanced liver fibrosis. They should be considered for liver cancer surveillance and should be considered for referral to gastroenterologists and hepatologists. Based on the previous study, the positive predictive value for cirrhosis for liver stiffness measurement more than 15 kilopascal is between 86 to 92%. Those patients who have liver stiffness measurement more than 20 to 25 kilopascal, especially in the presence of thrombocytopenia, are likely to have clinically significant portal hypertension. They should be considered for liver cancer surveillance and varicose screening. They should be referred to a gastroenterologist or hepatologist. I've touched a bit about varicose screening and liver cancer surveillance for high-risk patients. Next, I will talk about pharmacological treatment for NAFLD or MAFLD. There are currently no FDA-approved pharmacological treatment for NAFLD. However, there are medications that are already commercially available that may be useful for our patient with NAFLD or MAFLD. These include sodium glucose cotransporter 2 or SGLT2 inhibitor. It acts by blocking reabsorption of glucose in the kidney, therefore increasing glucose excretion and lowering blood glucose level. It is licensed as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. We performed a pilot study on empagliflozin, which is a SGLT2 inhibitor for patients with biopsy-proven NASH. This was a single-arm, open-label study, and patients were given empagliflozin 25 mg daily for 24 weeks. And at the end of treatment, they had a repeat liver biopsy. The study only included 9 patients, and as you can see here, there was a significant improvement in metabolic profile. There was significant reduction in BMI and waist circumference, systolic and diastolic blood pressure, fasting blood glucose, as well as total cholesterol level. There was also significant reduction in the serum GGT level, as well as MRI measured volumetric liver fat fraction. there was a significant decrease in steatosis grade, ballooning grade, as well as fibrosis stage. The histological changes were compared with a historical placebo, and as you can see here, the improvement in steatosis, ballooning, and fibrosis remain significant. So what I have shown you earlier was a single-arm open-label study. Of course, we need a randomized control trial to have good evidence that SGLT2 inhibitor works for NASH. So here is a randomized control trial of empagliflozin, 10 mg daily versus placebo in patients with diabetes and NAFLD. Patient had MRI PDFF at the beginning of the study and repeat MRI PDFF after 20 weeks. As you can see here, patients who received empagliflozin had significant reduction in their liver fat, which was not seen among patients who received placebo. Furthermore, the difference was significant when comparing the two groups. However, this does not meet the criteria required for registration of a drug for the treatment of NASH. Nevertheless, it does provide us with some evidence that SGLT2 such as empagliflozin may have a potential role in the treatment of NAFLD or MAFLD. Another class of drug that I would like to touch on would be the glucagon-like peptide 1 receptor agonist. This group of drug acts by delaying gastric emptying, increasing insulin secretion, and decreasing hepatic gluconeogenesis by decreasing glucagon secretion. So the LEAN trial was a multi-center randomized double-blind placebo-controlled trial that included overweight patients with biopsy-proven NASH, and they were randomized to receive either liraglutide 1.8 mg daily or placebo for 48 weeks. The primary efficacy outcome was resolution of definite NASH with no worsening fibrosis. This study included patients with and without diabetes and included a large proportion of patients with advanced liver fibrosis. A significantly larger proportion of patients who received liraglutide had NASH resolution compared with placebo, and there was also significantly lower progression of fibrosis among those who received liraglutide compared with placebo. This is another study on a GLP-1 agonist, semaglutide, that included patients with biopsy-proven NASH with F1 to F3 fibrosis. Patients were randomized to semaglutide 0.1 mg daily, 0.2 mg daily, or 0.4 mg daily, or placebo for 72 weeks. As you can see here, patients who receive the different doses of semaglutide had significantly greater NASH resolution compared with placebo. However, there was no significant difference in terms of fibrosis improvement. Mr. Chairperson, ladies and gentlemen, I would like to conclude by saying that NAFLD or MAFLD is the liver manifestation of the metabolic syndrome, and it is necessary for us to engage all stakeholders to optimize the comprehensive care of patients with NAFLD or MAFLD. Particularly, a clear assessment and referral pathway is needed so that patients with more severe MAFLD can be linked to gastroenterologist or hepatologist care, while patients with less severe MAFLD can remain in primary care or endocrinology where they are best managed. Thank you very much for your attention, and I'll be happy to take any questions.
Thank you, Professor Chan, your wonderful lecture. I'd like to introduce the second speaker, the Seung-up Kim, Korea. He is the professor of Yonsei University College of Medicine and also Liver Center. He is a director of a publication committee of CASL and also editor-in-chief, clinical and molecular hepatology, which journal is impact factor is now more than 6. And he sits on editorial board for Journal of Gastroenterology and Hepatology, and also work as associate editor, Gut and Liver, and also World Journal of Gastroenterology. So he now do very active to do research and publication as well. Professor Kim's main research field is viral hepatitis, and especially fibrosis and liver cancer. And also, he now focus on the non-alcoholic fatty liver disease these days. He will give us talk entitled Sarcopenia in NAFLD and MAFLD. Please, Professor Kim.
First of all, I would like to thank Hisky Medical Technology Company for providing a chance to give a lecture at today's very important symposium. In addition, I'm very honored to have Professor Sang-Hoon An as a chair and to listen to the lecture of Professor Chen-Hwa Kwang. Hopefully, this symposium will be a fruitful time for the audience. The topic of my lecture today is sarcopenia in NAFLD or MAFLD. So far, most of the studies related to sarcopenia have been reported mainly in patients with cirrhosis. However, with the recent increase in the importance of non-alcoholic fatty liver disease, a number of studies reporting the association between sarcopenia and NAFLD are being published. If you search PubMed using sarcopenia and liver cirrhosis, you will find over 400 articles. In addition, if you search using sarcopenia and NAFLD, you will find about 150 papers. However, as metabolic dysfunction associated fatty liver disease has recently received attention, studies on the relationship between sarcopenia and MAFLD have been gradually reported. What is the definition of sarcopenia? Traditionally, sarcopenia has been defined as a progressive and generalized skeletal muscle disorder associated with an increased likelihood of adverse outcome including fall, fracture, disability, and mortality. This concept includes both muscle mass and muscle strength or muscle performance. Until recently, working groups in Europe, Asia, and Japan reported guidelines related to sarcopenia. However, with the increasing importance of sarcopenia as well as malnutrition and frailty, the guideline was also published in the United States. AASLD guideline also adopted the theoretical definition. However, because most studies related to sarcopenia have defined sarcopenia based on the muscle mass only, the phenotypic representation of loss of muscle mass was adopted as the operational definition. Asia Working Group defines sarcopenia as follows. The definition and diagnosis of sarcopenia are still evolving as new findings challenge current understanding. Asia Working Group retains its original definition of age-related loss of skeletal muscle mass plus loss of muscle strength and/or reduced physical performance without reference to comorbidity. Therefore, we will not recommend specific diagnostic criteria or treatment unless and until more convincing evidence becomes available. How can we diagnose sarcopenia? As you can see from the table, there are various ways to measure the three components: muscle mass, muscle strength, and muscle performance. Among these examination methods, the skeletal muscle index seen on CT scan is recommended as the gold standard. Of course, not only the difficulty of performing CT scan only for the diagnosis of sarcopenia, but also radiation hazard and cost issues must be considered. As mentioned earlier, the AASLD guideline also presented a table summarizing various examination methods to assess sarcopenia, and also presented the skeletal muscle index measured using CT scan as the gold standard. The Asia Working Group proposed a diagnosis flow. As shown on the left, in the primary health care or community prevention services setting, the risk group is first selected with the measurement of cuff circumference or questionnaires such as SARC-F and SARC-CAF. Then muscle strength or muscle performance is measured. If specific criteria are satisfied, possible sarcopenia is assumed. In this case, lifestyle modification is sometimes recommended, and you can see that it goes to the right for more confirmative diagnosis. The figure on the right shows the diagnosis flow in acute to chronic healthcare or clinical research setting. As shown in the figure, either a specific clinical condition suspected of sarcopenia or a risk group is selected through the measurement of cuff circumference or questionnaire. Subsequently, muscle strength, performance, and appendicular skeletal muscle mass were measured. After that, if certain criteria are met, sarcopenia or severe sarcopenia can be diagnosed. Even in Europe, the flow looks a little bit different, but the main determining factors are the same. In other words, the diagnosis is made by measuring walking speed indicating performance, grip strength indicating strength, and muscle mass. Although CT scan is the gold standard, it is not easy to use in routine daily practice due to the aforementioned problems. Therefore, bioimpedance analysis, which can easily measure muscle mass, is often used. As shown in the upper left figure, there is very high correlation between muscle mass assessed by CT scan and by bioimpedance analysis. The upper right figure shows that the strong correlation is maintained even when body mass index is adjusted. However, the diagnosis of sarcopenia using CT scan or bioimpedance analysis must eventually use a specific cutoff value. Accordingly, you can see that the diagnosis is inconsistent in about 1 in 4 people. Let's take a brief look at the mechanism. In patients with NAFLD, sarcopenia and NAFLD influence each other through the liver muscle axis. As shown in the figure, insulin resistance, vitamin D deficiency, chronic inflammation, myostatin, myokine, and physical inactivity are mediated in the middle between sarcopenia and NAFLD. In the case of healthy condition on the left, insulin, growth hormone, physical activity, and testosterone activate the AKT and mTOR pathway to promote muscle protein synthesis, resulting in increased muscle mass. However, as shown in the figure on the right, in chronic liver diseases, amino acid production decreases, ammonia increases in blood, inflammation continues, growth and sex hormone abnormality occur, and myostatin is activated, all of which are inhibiting AKT-mTOR pathway and activating proteolytic degradation, resulting in sarcopenia. Let's talk about prevalence. Unidentified sarcopenia has a high prevalence that cannot be ignored. In particular, as fibrosis progresses, the prevalence is reported to be as high as 60%. Looking at our institutional data for HBV and NAFLD patients, it can be seen that the prevalence of sarcopenia measured by bioimpedance analysis is about 10%, although it will vary depending on how the cutoff is set. If you look at the bottom, you can see the difference in muscle mass. In addition, patients with sarcopenia showed an unfavorable tendency in demographical variable and fasting glucose. The fibrotic and steatotic burden measured by transient elastography is higher in patients with sarcopenia. The horizontal line represents the average of 10% in the entire patient group. It can be seen that the prevalence is relatively higher in the elderly, male, and those with non-viral etiology, significant fibrosis, or fatty liver. This table shows the prevalence of sarcopenia in patients with MAFLD. In the left column, you can see the characteristics of patients without MAFLD, whereas you can see on the right those of patients with MAFLD. In the group with MAFLD, the prevalence of sarcopenia was about 30%, and in the case of significant fibrosis, the prevalence increased to about 42% in MAFLD patients. Looking at the table summarizing the result of existing studies, it can be seen that the prevalence of sarcopenia is around 10 to 20%. However, if the target group is limited only to the patient with liver cirrhosis, it can be seen that the prevalence of sarcopenia increases up to 40 to 50%. It is easy to understand when considering that liver cirrhosis is a status of advanced liver disease. Interestingly, the prevalence of sarcopenia varies according to gender. A Canadian study of patients on the transplantation waiting list found that the prevalence of sarcopenia increased with advanced stage of liver disease, especially in male. As can be seen in the upper figure, the survival rate varies depending on the presence or absence of sarcopenia in men, but not in women. All of these prove that sarcopenia potentially has a gender difference. Sarcopenia accompanied by an increase in fat mass, that is sarcopenic obesity, is also attracting attention as an adverse predictor in cirrhotic patients. Sarcopenic obesity is defined as decreased muscle mass with increased fat mass. This is associated with an increased risk of metabolic dysfunction, liver dysfunction, mobility disability, frailty, increased healthcare cost, and all-cause mortality. This phenotype presents a unique clinical challenge. However, because fat mass can mask underlying muscle wasting, sarcopenic obesity can be difficult to detect. In previous study, the prevalence of sarcopenic obesity in liver cirrhosis was reported to be as low as 10% to as high as 30%. In a recent unpublished study by our team, based on nationwide health information database of the National Health Insurance Services, the single provider of universal healthcare coverage in Korea, which investigated the prevalence and risk factor of sarcopenic obesity in NAFLD, the prevalence of sarcopenic obesity was 5.2%. As shown in the figure, the prevalence of significant liver fibrosis evaluated through FIFO score, NAFLD fibrosis score, and FAT score was 3 to 4 times higher in those with sarcopenic obesity than those without. The coronary risk assessed by ASCVD also increases approximately threefold in the presence of sarcopenic obesity. Given that liver fibrosis or CVD risk, which are poor prognostic factor, increases in the presence of sarcopenic obesity, appropriate diagnosis and follow-up of patients with sarcopenic obesity is needed in the future. In NAFLD, sarcopenia is associated with liver fibrosis and metabolic features independently. In our previous study, the likelihood of NAFLD was higher in the presence of sarcopenia, and this relationship remained significant regardless of obesity or metabolic syndrome. When NAFLD was defined with various calculation markers, the risk of NAFLD was approximately 3 to 4 times higher in the presence of sarcopenia than in the absence. Even when the effect of other factors were adjusted, the risk was significantly increased by about 1.2 times. Unlike the previous study, this study was conducted only on the patient with NAFLD. When the fibrotic burden was measured using various calculation markers, the proportion of patients with highest fibrotic burden, that is the darkest black bar, decreased as the muscle mass increased, that is toward the right on the x-axis. In the same study, patients with sarcopenia had a higher fibrotic burden than patients without sarcopenia, which was maintained regardless of body mass index as shown in the left figure or insulin resistance as shown in the right figure. Such an independent correlation between liver fibrosis and sarcopenia was similarly reproduced in Western studies. In patients with histologically confirmed NAFLD, sarcopenia was confirmed to increase the risk of advanced liver fibrosis by about 2.3 times. Although not a study on patients with NAFLD, I'd like to introduce interesting result. This study was analyzed in patients with HBV. In this study, the relationship between sarcopenia and liver fibrosis was found to have an independent correlation. However, the difference was more clear in the metabolically unhealthy group, that is, the patient with central obesity, metabolic syndrome, fatty liver, or a patient who did not exercise. I think you are well aware that the concept of MAFLD has been recently proposed. Based on our recent study, we found that the subtyping of MAFLD according to the presence or absence of sarcopenia is possible. The second column shows the clinical characteristics of a patient with a MAFLD, and the right side shows the characteristics of the MAFLD patient group. Compared to non-MAFLD patient, MAFLD patients have higher steatotic and fibrotic burden and higher cardiovascular risk. Comparing within MAFLD, sarcopenic patients have higher steatosis, fibrosis, and CVD risk as well. On the left is the calculation of fibrosis using FIB-4, and on the right is the figure using NAFLD fibrosis score. As can be seen in the figure, the fraction of patients with the highest quartile of fibrotic burden expressed by the darkest black bar in non-MAFLD on the left is the smallest, and the group with MAFLD together with sarcopenia on the far right has the highest proportion of patients with the highest quartile of fibrotic burden. Similarly, the proportion of patients with highest quartile of CVD risk was lowest in the non-MAFLD group. Conversely, in the group with MAFLD together with sarcopenia, it was highest. This study analyzed the correlation between NAFLD, sarcopenia, and CVD risk in about 7,000 subjects. You can see the figure on the left when NAFLD was defined with a comprehensive NAFLD score, and the figure on the right when NAFLD was defined with a fatty liver index. When the leftmost group without NAFLD nor sarcopenia was used as a reference, the proportion of patients with high CVD risk increased significantly as the group moved to the right. NAFLD only, sarcopenia only, and double positive group. Compared to the reference, the rightmost group with double positivity has about 6 to 7 times higher risk of high CVD risk. In the fully adjusted model, the odds ratio for the double positive group to have a high CVD risk is around 2. This figure shows the CVD risk according to the presence or absence of FIB-4 score-based fibrosis and sarcopenia in the subgroup with NAFLD. As shown in the figure, when the patient group without sarcopenia nor significant liver fibrosis is used as a reference, the patient with sarcopenia and significant liver fibrosis has a 13 times higher probability of high CVD risk. In the fully adjusted model, the odds ratio for the double positive group to have a high CVD risk is around 3.5. I will talk about the effect of sarcopenia on the prognosis. Sarcopenia is well known to affect the prognosis in various diseases. This Canadian study included cirrhotic patients on a transplantation waiting list. As shown in the figure above, it can be seen that sarcopenia affects survival. The figure below shows that sarcopenia affects the prognosis in low MAFLD but has no effect in high MAFLD. Because patients with high MAFLD have end-stage diseases, it is easy to understand that sarcopenia did not affect the prognosis. This study included about 600 patients with various liver diseases. And as shown in the figure, it can be seen that sarcopenia affects the overall survival. In a recent meta-analysis, sarcopenia was reported to significantly increase the risk of mortality. In addition to mortality, sarcopenia is well known to affect varying outcomes such as HCC, transplantation, decompensation, quality of life, infection, and hospitalization. Sarcopenia is not only cross-sectionally related to NAFLD, but also affects the occurrence and disappearance of NAFLD, as shown in the figure. In the figure on the left, you can see that the highest total muscle mass group had a higher NAFLD-free survival. In addition, as shown in the figure on the right, you can see that the NAFLD resolution significantly increased in the group with a large increase in the skeletal muscle index over 1 year. Let's summarize the treatment of sarcopenia. According to the result of an old study, muscle mass, performance, and strength tend to increase when BCAA, exercise, or their combination are applied, rather than health education only. Recently, the result of a clinical study using a humanized myostatin antibody were also published. As you can see, compared to the control group, the appendicular lean body mass increased, the fat mass decreased, and the gait speed increased in the humanized myostatin antibody group, indicated by the blue line. In addition, clinical trials for various interventions are in progress. You can see clinical trial regarding behavioral intervention through exercise. Clinical studies related to dietary intervention using BCAA are also in progress. Clinical trials combining dietary and behavioral interventions are also ongoing. I will show some guidelines for sarcopenia. Unfortunately, there is no management guideline for sarcopenia in Korea yet, but some content are included in the liver cirrhosis guideline. Nutritional deficit and sarcopenia can be unfavorable prognostic factors in cirrhotic patients. Protein intake is required, which prevents sarcopenia and improve the prognosis. Exercise improves long-term prognosis in cirrhotic patients by preventing muscle loss. In AASLD guideline, objective assessment of muscle loss is required for cirrhotic patients, and measurement of muscle mass through CT scan is recommended. However, it should not be used routinely, and if CT scan is performed in a general care process, it is recommended to measure muscle mass using it. As shown in the figure, AASLD guideline has 3 levels of disease prevention and health promotion for the management of sarcopenia in cirrhotic patients. The Japanese guideline also emphasizes assessment for sarcopenia in cirrhotic patients because it affects the prognosis. Let me conclude my presentation. There are compelling evidences to show that sarcopenia is independently associated with significant liver fibrosis or cirrhosis in chronic liver diseases, including NAFLD. NAFLD or MAFLD has shown an independent association with the increased risk of sarcopenia. Sarcopenia adversely affects long-term outcomes, including CVD and mortality during the entire course of chronic liver diseases. Identification of high-risk population and appropriate medical intervention is required. Thank you for your attention.
Thank you, Professor Kim. Actually, while you are talking the lecture, actually there was 3 questions on QA box. So Professor Chen answered properly in real time, so saved our time. So I just summarize some questions and his answer, and continue to the more question and the comment and answers. Actually, the liver disease, the first question is reversibility of liver disease. So most of liver disease, including the NAFLD and viral hepatitis, can be reversible when the reversible of fibrosis, even cirrhosis, when the underlying disease is well controlled. So here the liver stiffness 10 kilopascal is around the F3 is now reversible when the lifestyle and modification and weight loss can be resolved. Professor Chen answered. And the second question was how do we recommend the patient for fasting, the no food before the transient elastogram exam? So there are some, the theoretical, the elevation of, theoretically the elevation of liver stiffness measurement might be slightly increased after food. So there's an increased flow, blood flow to the portal vein. But here, Professor Chen answered between 2 and 4 hours of fasting. I also agree with him. And there's 1 or 2 hours might not a big difference, so quite similar. And the other one was, the liver stiffness measurement. Transient elastography do not measure liver size, just measure the stiffness and degree of fatty liver disease, degree of liver hepatic steatosis. And there's one, the case study, question. So already, Professor Chen answered, but Professor Kim also can give us a more comment on this patient, 33-year-old, the young gentleman, slightly elevated the liver enzyme, ALT, and slightly abnormal lipid profile, but the hemoglobin A1C level is high, 8.2, may have a diabetes, but this patient have a, the higher number of liver stiffness measurement, 11.3 kilopascal, and enlarged liver. So how do we treat these patients to reverse, his fatty liver, even though his liver profile is slightly elevated? So Professor Chen answered. Also, I think there's a poorly controlled diabetes. So this is one of the main reason why he has a severe fatty liver, regardless of severe dyslipidemia. So I think he can check the other one, maybe obesity or others, but diabetes is the main cause. So how's Professor Kim's opinion on this patient?
I also think that lifestyle intervention and weight loss is the main medical intervention, and also the anti-diabetic medication is also important.
Okay, so and I will give several questions to two speakers. Actually, the Professor Chen. So we sometimes encounter the lean fatty liver patient. So know the severe metabolic syndrome, but this is not frequent, but sometimes. So what lifestyle change are recommended for this lean fatty liver or MAFLD patient?
Thank you, Professor An, for the question. Essentially, when we define lean, NAFLD or MAFLD, we look at their BMI. But in reality, most of these lean NAFLD or MAFLD patients, they actually have visceral adiposity. I would still advise them to go on lifestyle change. And during my talk earlier, I did show a study whereby when even among those patients who are non-obese, lifestyle change and weight loss can lead to remission of their fatty liver. Yeah, so lifestyle change is still the mainstay of treatment, even in those non-obese patients.
How do you recommend the exercise for this patient to increase muscle mass?
Yes, so of course, in younger fetal patients, they could, with good cardiorespiratory fitness, they could perform aerobic exercise. Whereas in those older patients where they are not so fit in terms of their cardiorespiratory fitness, even resistant exercise would be good. But at the end of the day, I will ask the patient what type of exercise they like to do. So patients, they don't like to jog because it's just so boring, but they like to play sport games. So it's really tailored to the individual patient's interests in terms of the exercise that I recommend.
Thank you. Professor Kim?
Yes.
You said in your lecture, so you need to check all of the muscle mass, muscle strength and physical performance to diagnose sarcopenia, but how can it be applied in daily routine clinical practice? Three measurement.
Thank you for your good question. As you said, the original definition of sarcopenia can be decided after checking all three components, but in actual clinical practice, it is very difficult to measure all these things. So I think this is the reason why AASLD adopted the operational definition based on muscle mass only. So currently our institution is mainly measuring muscle mass using the bioimpedance analysis. And recently we are building a database of grip strength to measure muscle strength. We also plan to analyze the relationship between grip strength and muscle mass and how grip strength can be used for the diagnosis or stratification of sarcopenia. In addition, because it has been reported that the prevalence of sarcopenia in NAFLD is very high, and the relationship between sarcopenia and NAFLD severity has been also proven. So we are now prescribing DEXA for more exact evaluation for muscle mass. So I also want to ask Professor Chen for this issue. So what is your clinical practice?
Yeah, so indeed, sarcopenia in NAFLD or MAFLD is a very hot area, but I agree with what you have said earlier about sarcopenia with sarcopenic obesity. We see more severe liver disease as well. But in terms of clinical practice, we have not started to evaluate our patients here for sarcopenia, although we are really interested to do so. At this point in time, it's not done in clinical practice yet, at least in our center. But like you mentioned, I think it's something important that we need to explore. And of course, to see whether improving their muscle mass and muscle strength would indeed help improve their long-term outcome. I think this is certainly something very interesting that we need to look into.
Okay, there's one question from the participant, Huang. From clinical perspective, what is your comment on just a classical transient elastography versus B-mode imaging-guided transient elastography? Two speakers, please comment briefly.
So maybe I can start first. I think it may be a bit different, the perspective from Malaysia and from Korea. In Malaysia, our gastroenterologists and or hepatologists are not trained to perform ultrasound examination of the liver. So we usually will do the transient elastography ourselves, and we don't do ultrasound examination ourselves. Although if we have ultrasound to guide us to locate the area to measure transient elastography, I think we may be able to get less unsuccessful measurement, but we do not generally do ultrasound examination for our patient.
How about the Professor Kim?
Yes, we have both transient elastography and B-mode imaging guided transient elastography, but you know, the physician has no time to measure the stiffness. So we have a nurse or technician to measure the transient elastography, but you know, the doctor should use the B-mode imaging guided transient elastography. So nowadays we do not usually prescribe the B-mode transient elastography, just the normal transient elastography, because we don't need to spend our time to measure the stiffness. And in our previous study, we compared the accuracy of between two modalities, but the accuracy was a little bit higher in the transient elastography than the B-mode transient elastography. Although the overall accuracy is similar or a little bit superior in the B-mode imaging guided transient elastography, but in our experience, the accuracy is a little bit higher in transient elastography.
Thank you for your comment. Actually, there's more data and evidence with the classical elastography currently. So I think B-mode imaging guided elastography maybe benefit to localize some area, whether that spot is more specifically the hardened or not, but usually the accuracy of the data, usually classical elastography may be better. So there's a more the practical currently, but maybe later that might be changed to imaging guided transient elastography if data is more accumulated. And I will give you two speakers. The last question maybe, if there's no question from participant. Actually, Professor Chen introduced several new drugs for the NASH, the in clinical trial in development. but mostly, these drugs is for the biopsy-proven NASH rather than NAFLD and MAFLD. So you guys, which patient, NAFLD or MAFLD, are recommended a liver biopsy for pharmacological treatment or the aggressive, monitoring?
Maybe I can start first. So usually liver biopsy, we do it nowadays if we are unsure about the diagnosis, there's uncertainty about the diagnosis. So the biopsy would help us confirm whether indeed it is NASH or whether there's some other etiology like autoimmune hepatitis. So number one is when there's uncertainty about the diagnosis. Number two, in some patients, when there's discordant result between the non-invasive test and we are not really certain whether the patient indeed, for example, has cirrhosis, so liver biopsy may be considered. But other than that, the other reason we perform a liver biopsy is for enrollment in clinical trial. But other than that, some of the drugs that I mentioned earlier, like SGLT2 inhibitor and GLP-1 agonist, they are very safe medication that we prescribe for our diabetes patient. We don't really need to do a liver biopsy to confirm that they have NASH before we prescribe this medication. And as I mentioned earlier, and I'd like to emphasize this, so SGLT2 is used for patients with diabetes. It's not licensed to treat fatty liver, but certainly if I have a patient with fatty liver and diabetes, I would really consider giving the medication to treat the diabetes because it will help with the fatty liver as well, although data are quite preliminary. Same goes for GLP-1 agonists. So it's licensed for diabetes as well as obesity, but not for fatty liver. But certainly if I have patients with fatty liver who have diabetes or who is obese, then I would tend to prescribe it for the patient. That will be my take, Professor An.
Okay, thank you. How's Professor Kim in your real clinical practice? So which patient do you recommend the liver biopsy?
So as the Professor Chen already presented, the single most important factor is fibrotic burden in NAFLD. So I just decide to perform the liver biopsy or not based on the fibrosis, mainly based on the transient elastropy, probably 7 or 8 kilopascal. That is the only the factor to perform the liver biopsy, regardless of diabetes or metabolic factors. So I also usually prescribe the GLP-1 agonist for the NAFLD patient with significant fibrosis, regardless of diabetes. In Korea, we can prescribe the GLP-1 agonist if there is no diabetes.
Okay, there's one more question. Our team suspect that the non-liver tissue intrahepatic vessels will affect stiffness values. Without B-mode imaging guidance, it is difficult to avoid the vessel when we are scanning our patient. Could we have your comment on this? So how much, the vessels in the liver will affect the measurement of transient elastography if we do not localize the site of measurement?
So yes, I think your question is right. So the propagation ultrasound can be interfered by the vessel, but if there is no B-mode imaging, the classical transient elastography also has some kind of some black and white the 2D mode scan. So if there is a vessel, you can see not the vessel, but you can see the presence of the vessel on the B mode screen on the classical fibroscan machine. So I think that this is not a big issue because if you can see some shadow of the vessel, you can choose another spot to measure the stiffness.
Okay. Is there any additional comment from Chen?
Yes, I agree with Professor Kim. So the current transient elastography, we have the A mode and TM mode. That itself can actually help us avoid a vessel in most instances. And I think the effect would be minimal. But I just want to add on, I think I saw Huang asking a question about FibroScan, FibroTouch as well. So we did have experience comparing measurement from both devices simultaneously in the same patient. And we found that the reading from FibroTouch and FibroScan, they are very strongly correlated. But FibroTouch does have the advantage of just one probe. It does not need to have different probe sizes. We found that the time for examination is a little bit shorter, although probably in practice, it doesn't really matter. And we actually have very low, in fact, we didn't have any invalid measurement with the FibroTouch device. The only thing is we noticed that the FibroTouch reading, it tends to be a little lower at higher readings and a little bit higher at lower readings. But it's only very marginal in terms of the difference. But I guess the important thing is we are able to measure the stiffness of the liver. So when there's more fibrosis, the measurement will be higher. So and both FibroTouch and FibroScan, they actually correlate very well with each other. So that will be my take on the two devices.
Okay, thank you.
I also have some comment. I think the most people are getting obese these days. So I think the B mode transient elastography will be required more and more in the future, I think.
Okay, thank you very much. Actually, this is a very wonderful symposium hosted by the Hisky. I really appreciated the Hisky company and the two professors. The very active and well-known professors in this field. The Professor Chen and Professor Kim's, the speaking was very informative and impressive. Next year, Korea will hold a parcel the end of the March. Hopefully, the well-controlled COVID-19, and we welcome the participant here in symposium come to Korea. Thank you. Thank you, speakers.
Thank you very much.
The company participant. Bye-bye.
Bye.
Bye-bye. Thank you.
Bye.
Bye-bye.